I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Hegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
59-year-old postmenopausal woman presenting with stage 4 invasive ductal carcinoma, ERPR negative and HER2 positive, with a pathologic fracture of L5 and right femoral neck and likely lung metastasis in the presence of a large fungating breast mass. And so the questions that have been posed, the role of surgery for this patient prior to any other treatment, what sort of systemic therapy options would be recommended, and then specifically for the metastatic bony disease, which areas would we recommend radiation therapy and for what duration? So Dr. Jockelson, we might have you point out some of these kind of difficult, unfortunate findings on imaging here for us.
Sure. Okay, so we're beginning with a chest CT in the axial and sagittal planes. I want to point out there are no lung windows, so I really can't address the possibility of pulmonary metastases. But the primary findings here, which are certainly extremely important is the local disease that she has on the left. And the windows are not ideal for looking at fungating or not fungating, but you can see this huge mass with skin irregularity. You can see that the mass is extending into the pectoralis muscle. I don't see it on the axial images extending into the chest wall. Looking at it on a single slice in the sagittal, it's very hard to see whether or not it would be extending in the chest wall on a different slice. You really have to look at the whole exam. But what you're definitely seeing is a very large mass. In addition, she has left axillary adenopathy. There's 2 nodes you can see here. On one image on the right, I do see a subcutaneous or an axillary nodule. Again, I'm only seeing it in one image. It's since we know she has distant metastases, it's nothing that really has to specifically be worked up. But this is just in terms of the local disease, and I know there's some bone images on subsequent slices. So what we have here is we have plain films of the right hip, and more just as a teaching point, you can see a large lytic area, and people use terms impending fractures, where the definition is that it takes up 1/2 to 2/3 of the medullary shaft, but you can see here that you actually have a break in the cortex already. So this is a fracture, it's just not initially displaced, and so the patient did have a total hip replacement to treat that. And then there's one more. So she has a compression fracture secondary to metastatic disease in L5. And the important information here is you can see that the fractured bone extends posteriorly into the spinal canal. And it's very hard on this one image to see if there's any epidural tumor separate from that, but there is fractured bone going into the canal, and whether or not she's got any neurologic or any problems secondary to that, this would be something that really you'd have to know how symptomatic she is. If it's really symptomatic, even radiation is not going to reduce that fractured segment of bone, so that might need to be unroofed or not, depending on symptoms. So.
Perfect. Thank you so much. So a little bit more about the patient's treatment history. She was started on weekly paclitaxel while hospitalized, minimal improvement in the breast mass. She, as you mentioned, did undergo the orthopedic surgery, the replacement of the hip, and then she received palliative radiation to 30 gray and 10 fractions to L4 through S1. And the plan was to radiate the right femur, again, after the surgical intervention. And so, Dr. Shah, do you want to comment about the radiation and any other areas that you think radiation would be important, or any other nuances that you think we should point out?
Sure. So working our way through the areas, I would agree with, in terms of the right femoral neck, that radiation is not alone going to help that area. So delayed surgical intervention on the right femoral neck and then adjuvant radiation to that area, I think would be the most prudent way to proceed. In terms of the spine, I'd have a discussion with my spine surgery colleagues on the potential, and certainly the patient's performance status and burden of metastatic disease will also bear on that. But in theory, if surgery would be possible, as it was noted, a large fracture radiation is not going to really modulate that quite a lot. So it could be a consideration for surgery followed by radiation. 30 gray and 10 fractions is one consideration. An alternative consideration might be high-dose stereotactic radiosurgery just to the level of L5, giving single-dose radiation therapy. In terms of the last area, the fungating breast mass is an area I would consider giving palliative radiation to. Obviously, I'd make sure that good skincare was being done. If there was any concerns for infection, using something like topical metronidazole powder, and then delivering palliative radiation to that area is something we would commonly do.
Okay, perfect. Thank you all.
Would you consider hyperthermia in addition in this patient because of such a large mass? I don't know how much you do for large intact tumors, but would you consider that?
It's a great question. It depends on the type of hyperthermia you have. So if it's cutaneous, you can use superficial hyperthermia or ultrasound based. With this type of mass, unless you have interstitial hyperthermia where you place needles into the breast, you're not going to be able to really get heating throughout the breast. And with such active disease throughout the breast, I'd be a bit reticent to place interstitial catheters to deliver hyperthermia.
Dr. Pegram, do you want to comment about any systemic therapy options for her?
Yes, in light of the fact that these patients, when treated with our current armamentarium of HER2 targeted therapy, usually beginning with a taxane plus trastuzumab plus pertuzumab, these patients could do very well for a very long period of time. So the orthopedic surgery and radiation therapy are critical in order to facilitate her recovery from the orthopedic complications that she suffered from metastatic disease. So I would have also chosen a taxane, probably weekly paclitaxel, along with dual antibody therapy, perhaps even preoperatively. Particularly, you could sometimes start with the two antibodies if the orthopedic surgery is imminent, and then layer in the weekly paclitaxel on subsequent cycles after she's completed all of her local control for the orthopedic complications, in this case, hip fracture. So it's pretty easy to do that. The dual antibodies have no impact on wound healing, et cetera, as compared to a chemo-based regimen to start out. So there are lots of good options here. And then upon future progression of a Cleopatra-like regimen, there's an untold number of good options at that point, ranging from TDM1 to the tucatinib-based HER2 regimen, to fam trastuzumab deruxtecan, and now more recently, chemo plus margetuximab in the salvage setting has recently been approved by the FDA as well. So this patient has a long future in front of her if she is fortunate enough to respond and recuperate well from her orthopedic surgery. And I would be very ambitious in terms of getting her disease under control with systemic therapy post-op.
Perfect. Thank you so much.
Also, a bone-acting agent long-term also is indicated, obviously, in this case.
Thank you so much for that. I appreciate that.